So if I can have all the speakers come up front so that we can have our panel discussion. So I'll start off quickly with a question directed to Dr. Jensen. So should we consider obesity more of a spectrum condition and such that in these studies, how much have you looked at when the onset of overweight or obesity happens versus the disease mortality risk?
Well, fair enough. A good question, which is, are we getting a sizable cohort of older people who are becoming, markedly overweight or obese later in life? There's not a lot of really robust data looking at that question, though what I have seen would suggest that many of the people that we're studying now, following now, were overweight or obese in middle age and sometimes even younger. Obviously, you will, in women, for example, see a lot of postmenopausal changes as well. I think it is very much a spectrum. We've done a lot of work looking at nutritional status in overweight and obese older people. And in fact, many of them are undernourished. They eat such poor quality diets. We've documented multiple micronutrient deficiencies. They may not be for want of food energy, but they're still consuming very poor quality diets. And of course, it's quite possible to be large, mobility limited, homebound, and yet be undernourished at the same time. So it's definitely a spectrum.
And I have one more question then for the panel here with regard to biomarkers. So in the first session, we heard mention of biomarkers, and again here, and sometimes it's bucketed into 5 categories or 4. So, and we'll hear more talks as the workshop proceeds, looking at specific organ systems. But are there biomarkers which sort of rise to the top at this stage in your minds about being most indicative or most warranting further evaluation?
That's a loaded question. I'll try to address to the extent that is possible. So there are certainly biomarkers of aging that are emerging and that seems to be absolutely robust in terms of tracking, chronological age. I mean, if you look at the methylation marker, what has been done by many scientists, you can predict the age of an individual with an R-square of 0.99. So if somebody today drop some blood on the floor, I can go there, take the DNA, read the DNA, and I can tell the sex and the age of that person with the precision of 1.5 years. So this is unbelievable. But then when we try to apply those biomarkers to what we're really interested in, is capturing the health and the biological age of that person, we're not there. I think that inflammation is probably the best we have, but it's a much better marker for short-term mortality than for long-term prediction. And I think that the others, still, I think that there is a generation studies that are coming. So the biomarker of aging that have been studied in animal model have been now translated in humans. People are starting to count how many senescent cells are in the skin. People are starting to understand in humans what is the ability to repair DNA. And then you can look at, using imaging technique, what is the function of mitochondria in your muscle. I think that those biomarkers will tell us a lot about biological aging, but will also tell us what are the mechanisms that in that specific individual we need to address in order to slow down aging.
Simin Meidani, Tufts University. I have a question for Gordon and a question for Luigi. So in terms of public health recommendation, given that the percentage of older people who are obese and healthy is very low, would you then say that it's probably best to stay within the 18 to 25 range? And is there modelings that can be used to determine that? Because it seems to me that it's only a small percentage of older people who are obese, even class 1, that are healthy.
Right. Yeah, it's a important observation since it's on the order of 10%, that range. Of course, what I'd like, in terms of public health perspective, I'm not even suggesting that we should change the 18.5 to 24.9. What I'm suggesting is we may want to rethink how we apply it. So as an example, the woman in the wheelchair that I showed in my slide, huge, housebound, wheelchair-bound, very functionally limited. The focus, is not going to be, my goodness, you're a gazillion pounds overweight, we need to take 100 pounds off you. The focus might better be on how do we preserve quality of life and function to the degree we can. So very much focus on flexibility, transfer, strength, those sorts of issues. That said, I think if we're talking about precision medicine, ultimately, as a goal here, it's not a question of one size fits all, because obviously you're among that 10%. You don't want people, rushing saying, my goodness, you're 30 pounds overweight, you need to lose 30 pounds in the next 6 weeks sort of thing. You'd like to continue, those people are going to outlive us all. So I guess I'm hedging my bet. So I think from a public health standpoint, absolutely reasonable to not change the current guidelines. I'd just like to rethink how we use them.
And then maybe a follow-up question to that is where the people, the obese people who were metabolically healthy, were they more active? I mean, did you get a sense of their physical activity levels?
We looked at that. The issue was that we were, for the particular question, what we had was self-report, single question screening of activity level that wasn't suitable to discriminate at this level. But that's an important question to revisit because, as I said, one of my key hypotheses would be the metabolically healthy, overweight, and obese people are likely to be the ones that perhaps don't have active chronic inflammation, are more likely to have intact lean mass, and you're right, I think would be likely to be more physically active, which will be anti-inflammatory in and of itself.
And if I may ask one more question from Luigi. So other than IL-6, which other inflammatory markers would you consider as a biomarker?
So the issue that we can only measure
We've been kind of waiting here.
biomarker in the blood. So when we measure something in the blood, is the echo of something missing that is occurring in the tissue. And so the choice is determined not only by what is important in the tissue, but what actually gets in the blood and can be stable and can be measured. So IL-6, I suspect that it's important, but we also have very good in measuring it. It's very stable in the blood. So it turned out to be one of the best I know. The other three that everybody finds that are really important are IL-1 receptor antagonist, which by far it's an anti-inflammatory, cytokine. But because it is produced by the liver under IL-1 stimulus, and because it stays in the blood for a week, you can measure it, and it's a very good proxy of the IL-1 signal. The other two are TNF-alpha receptor 1 and receptor 2. Again, they are shedded by the membrane at the time of the TNF-alpha receptor engagement. And because they stay in the blood for a long time, you know how much TNF-alpha signal is there. It's not that they are part of the signal, but again, the biomarker tells you something about the TNF-alpha. So in our hands, those are the four that always come up needed. And the others, we have a lot of data, IL-1, but it's very difficult to measure and not very good to measure
Well, if you were to name a functional biomarker of aging,
walking speed.
pardon?
Walking speed.
Walking
speed is the strongest predictor that we have about Oh, sorry. It's the strongest predictor that we have about mortality, disability, declining in health. It's unbelievably predictor. I didn't have the time, but we did a study in the Inchianti study, which is my Italian cohort, and we studied walking speed, the baseline, and then we had 9 years follow-up. Then we classify people in quintiles of walking speed, and the lowest quintile was 0.8 meters per second. And then we compare the predictive power of having a walking speed of less than 0.8 meters per second with the predictive power for mortality of having a malignant cancer. And the mortality associated with low walking speed was more powerful than having a malignant cancer. So that tells you how powerful it is.
Connie Weaver, Purdue. Thank you for an interesting session. My question is for Janet. Either I misunderstood you or we didn't close the loop. You were saying there was a publication out by Andrew Prentice's group, and I thought you said it was to address can you influence DNA methylation with micronutrient supplementation. So I expect you to follow up with the rainy, wet season to say, oh, you could recover it with micronutrient or not.
So actually they did 2 studies, Connie. And the first study was a supplementation study. And in that study, they were able to show that with the supplement of multiple micronutrients, they were able to change DNA methylation irrespective of where the woman was in the cycle of wet season versus rainy season. Then the second set of studies was they looked at the effect of the cycle of food availability on methylation and found that if the child was conceived during the rainy season, there was an increase in the blood biomarkers that are associated with methylation and an increase in gene methylation in those infants. No, they didn't look at that. Well, yes, they did, because they found no effect of the rainy season cycle in the supplementation study.
Yes, good morning. I have a comment for Janet. You talk about the study which pointed out that early exclusive breastfeeding in association with the length of telomeres among the 4 to 5 years old children. I think that is important, but however, we shouldn't forget that after 2 years of breastfeeding, the 3rd and 4th year nutrition and the quality of energy and calorie, it is very important. Dr. Luigi referred to periodontal disease. There is several studies for the children in West Virginia that their nutritional calorie mainly come from Mountain Dew. And that study is called Mountain Dew Mouth. And this kid, they grow up and there is a highest incidence of the oral cavity cancer, neck cancer, and brain cancer among those kids. So the 3rd and 4th year, it is also very significant. It is not exclusive breastfeeding alone, 1st year, 2nd year, but also the 3rd and 4th year is very important. The second comment and question that I have, it is regarding the origin of inflammation. I think obesity alone is not the origin of inflammation. What it is the level of oxygen in the blood and the glucose, which Dr. Jensen referred to it, which suck the oxygen from the blood. And also it caused the accumulation of the plaque in the artery. And it is the origin of everything, most chronic, multiple chronic condition among our population. Thank you.
Thank you for a very interesting panel. My name is Johanna Dwyer from NIH and Tufts. My question is back to the issue of Dr. Jensen's talk, but I think it also involves Dr. Ferrucci and perhaps Dr. Madden's. The end-stage renal disease population is very large in the United States. Many people are on hemodialysis, and I think everybody's inflamed who is, they're certainly not metabolically healthy. But as I remember from renal studies, the advantage of overweight is quite substantial on mortality and I believe also on morbidity, at least to some point. And so I was wondering whether you think that for that population it makes sense to have a different standard.
Great observation, Johanna. And of course, that really highlights a point that I tried to make repeatedly, that this is going to be very population specific. And of course, in my particular cohort study, we're basically focusing on community dwelling older individuals, who are, of course, bouncing in and out of the hospital, and at this point in their lives, many of them were dying as well. So I do think that will be very important. And of course, I give credit to my renal colleagues in terms of thinking about inflammation and its influence on outcomes, for example. I think perhaps they were way ahead of the curve in thinking about this. And there are, of course, times I wonder whether dialysis membranes themselves are a pro-inflammatory inciter, if you will. So indeed, there are certainly subsets where, again, being somewhat overweight or mildly obese is likely to have some survival benefit. Now, the issue in the kidney population will in fact be that a whole bunch of these people do have, obviously, metabolic risk, are in pro-inflammatory states. But when you look at what happens to chronic renal failure patients on dialysis, over time, they sort of slowly waste away before your eyes, and it wouldn't surprise me at all if there was not survival benefit to having some metabolic reserve to get through that. But I think the real issue is this highlights that what we're talking about is going to be very population specific and, of course, ultimately individual specific as well.
A fish outside the pond, it's really not what I study, but I think that when you look longitudinally in older individual, especially in sick individual with chronic kidney disease, what we see is that loss of weight is an incredibly strong predictor of mortality. When people start losing weight, they're going to die within 1 year. And so we don't know, in my opinion, at this point, without more longitudinal data, where those that are higher mortality, and it's not really a protection, it's the fact that if you allow to maintain a high weight, that means they are still not wasting. So you're not in a trajectory of the disease that is terminal. So it's protective, or is a biomarker that your disease is not so severe. I think longitudinal data will give us more an answer to dissect these two populations.
Good morning. Fascinating presentation. Thank you very much. I'm Mary Worstel. I'm with the HHS Office on Women's Health, and I'm not trying to make everything about the difference of the sexes, but I'm often struck by how we talk about aging in a one-size-fits-all. And I'm really very interested in any of the implications. Dr. King, I know you're speaking about women and pregnancy and so forth, but if we could just look at this and say, are there distinctions between the sexes in terms of what you're talking about, and highlight those so we know how better to message to both men and women. So if there's anything from your studies that could elucidate that, I'd really appreciate it.
Well, I highlighted a number of gender differences in my presentation. I suppose the simplest observation I would make when you start looking at populations of older people in the community setting, and then focus down on those who are overweight and obese, there's not a lot of men. All right, there are a lot of women. So that would be perhaps the most glaring gender difference right there. And so when you're talking about cohorts of advanced age, like I'm working with, it really is quite significant. And so, every one of those analyses you saw there, of course, we were controlling for gender, for age, for, as you saw, for everything we could possibly think of. I didn't want to bore you with all that data. But clearly, the gender implications are very important. And when I listed all those factors that are going to be key things, gender, age, population, metabolic health, body composition, and of course your genotype. So absolutely.
And going back to inflammation, the same thing. We find that the relationship between the steroid pro-inflammatory state of aging in population for different outcomes are substantially different between men and women. Women have much lower inflammation than men, but a small grading of inflammation has powerful effect on outcome more than in men. And the relationship between obesity and inflammation substantially different in men and women. I will say in women, really visceral obesity is a stronger risk factor for high inflammation. In men, it's absolutely not true. I want to make one comment that Rafa De Cabo made me think about. In the audience, we're talking about nutrition. 70% of people interested in nutrition seems to be women, and I probably it's not by chance.
I think we're going to have to close it up because we're just a little bit after 12. So thank you, everyone. Thanks to the speakers for their wonderful talks. So for food forum members and speakers, there'll be lunch available in the West Court. For the rest of you, there is in your program book directions to the cafeteria. So there's a cafeteria in the building. Session 3 will begin at 1 p.m. Thank you.